I got it.
Perfect.
Okay. People are about to figure out that I haven't done this before. Okay.
I had the same struggles. So now if you can display your presentation.
Okay.
And you should be able to see the poll now that you're can you see the poll? So down at the bottom before you share your screen, do you see?
Right. Stop share, relaunch poll.
Did you
Existing poll results continue?
Do you see an icon at the bottom that says polls?
It does, but what it pulls up, I'm assuming the poll that you did.
Right, so if you go to the top, yeah, but there's a click bar, like a little arrow. So then you just scroll down till you find your poll.
Oh, look at that. Okay. Fair enough. Okay. So now I'll do that for each slide, right?
Yeah, you'll just click back up to that little thing once we've, yeah, because you have a series of polls.
Yes. Okay.
Yeah.
Let's see how this goes.
Okay.
Oops. One moment.
So everyone, this is the X-ray OSCE. And if we get short on time, we may just do what I did with the pacemakers and just go through it and just ask everybody to verbally respond.
Sure, that's absolutely fine. I want to share my screen. If I share my screen, what do you guys see now?
Yeah, see it.
What do you see? No?
Well, we see Zoom 5.42 is here.
Well, that's not what I wanted you to see.
We saw, okay, there, but if you use the other icon, that one, yeah.
Yeah, now does that look like it?
Perfect.
Okay. All right, well, let's.
So now you might have to open up the poll and share. I'm not sure if you have to reshare or not.
Okay, let me, so if because right now in front, all I have is the poll. I actually can't see the presentation. So if I stop sharing, no,
maybe
that won't work.
We can see your presentation, but not the poll.
You can see the presentation?
Yeah.
Oh, I can only see the poll.
Okay, so maybe escape and then reshare your screen for the presentation.
Okay, I can do that. One moment. Let's put that down there. Share screen. Share. Okay, I can see my screen.
Okay.
All right, well, let's do one step at a time.
Yep.
Okay. Hi, everybody. So this is a very a basic chest X-ray review. So it's going to it amalgamates the first couple presentations that we've done. So if you're a radiologist, this is probably going to be a walk in the park for you. And if you're new to looking at chest X-rays, I can assure you the first bit for sure you'll be able to, you'll feel very comfortable with, okay? So let's talk about Jenna. Jenna's a 4-year-old post-operative conduit repair. She's had an uncomplicated course of care. Now she needs to have her routine chest X-ray. It's the morning X-ray, the daily X-ray, which we tend to do. So there's a couple of questions associated with this. What are the most common views that we see of chest X-rays in the intensive care? And what sorts of positioning would you see? So let's do, whoops, that's not what we wanted. Hang on. I'm learning along with you guys. Okay. So launch poll, Cecilia. There we go. So we can answer both of those questions and then we can talk about it just really briefly.
We can't see your poll.
You
might
can't
have
see my poll.
might have
I
to
can
share
see
your
the
screen
poll.
again. I think you just have to share your screen again because that was what happened to me this morning.
Okay. So share my screen again.
Yeah.
I can do that. It says I'm so new share.
Yeah, new share.
See it now. Some people are answering.
Oh,
Yeah,
are
I
they?
can
Okay.
see it.
Oh, you know what? It's just because I'm also a host, so I can't see it.
Oh, so you can't see it.
Ignore me.
Okay. It looks like everybody answered. Yeah. Okay, so and everybody answered correctly. So the most common view in the intensive care would be AP and lateral. Remember, when you go to a clinic or a walk-in clinic, we do posterior anterior views, right? You walk up to the x-ray plate and you put your chest against the x-ray plate. That's going to give you a posterior anterior view. This is important because if you go to look up chest x-rays on the internet or from a different source, you have to understand if you're looking at it posteriorly to the anterior side or from anterior to posterior, because the x-rays will look quite different. All right, and things that you want to think about when you position an x-ray, position a patient for an x-ray, you want to try and move all the leads and the tubes and such out of the field of the x-ray. You're going to try and get the patient's arms up. You're going to make sure that they have a good inspiration and that there is no rotation. That is incredibly difficult to do when you're dealing with small children, but you want their head midline and you want it in a neutral position. Okay, so relaunch polling. What do we do now?
Go back up to your poll. Do you see your next question?
Go back up to my poll.
And then find your next question, because remember, for yours, we did individual polls.
Right, got it. Except I need to go back to my slides. Okay. We seem to have advanced. There we are. Okay, so this is Jenna's X-ray. What I'd like to know is this a good quality film, and what sorts of things are you thinking about? What considerations do we have to say that you are going to make a good quality film? So let's go back to polls. One moment. There we go. So is it a good quality film? Yes or no? Can you see that? And then what sorts of things are taken into consideration for to produce a good quality film? Oh, look, everybody seems to have answered. So far, so good. Okay, so the vast majority of people answered no, it is not a good quality film. It is underpenetrated, so that is absolutely correct. And the things that you're going to think about and you're going to take into consideration would be projection, orientation, penetration, and the degree of inspiration. So all of those things together are things to consider to produce a good quality film. Okay. So we weren't very happy with that particular X-ray, so we repeated it. And this is her repeat X-ray. So when you're looking at an X-ray, there are a couple of things that you're thinking about. And everybody has a systematic approach, right? So which one of those are a systematic approach to looking at X-rays? Can you guys see?
Can see.
Can't see?
Can.
Oh. Yeah, it looks like the vast majority of people have answered. You're still thinking about it. So yeah, so there's a couple of different methods. It doesn't really matter which method you use, as long as you use a method which is, you use the same method the majority of the time. That way you're not going to miss anything. So A, B, C, D, E, F, G, H is a mnemonic for well, we're not going to get into the whole thing. And then the other approach, most people go from the outside in as opposed to the inside out, because as a general rule, we're focused as intensivists in general, we're looking at what's happening within the center of the X-ray. And often there are things that will give us clues to the clinical picture along the exterior of the X-ray as well. So it's good to look at that. All right, told you this wasn't going to be very hard. Okay. So these are just some basic structures. I understand that the X-ray, when you start projecting it digitally like this, it does get quite pixelated, but whoops, sorry people. But if you could just sort of identify some of these structures, I'll give you some choices. So you don't have to do it all from scratch. So can you see the pole and the structures at the same time? I guess you can, because people are. Well, it looks like okay. So it looks like a number of people answered, and everybody answered the same. Oh, I'm mistaken. Most people answered in the same manner. So this would, you could either call it the spinal processes, because you can actually see through to the vertebral column here, or this would be the trachea. If you squint really hard, you will see the bifurcation of the trachea. So this would be your carina. This is the perihilar area. It also has, it's sort of a vague area. And one of the things that we're always we're looking for a sharp, pointy costophrenic angle here. And that indicates to us that A, it's a decent inspiration, and B, that I have good differentiation between the radiopacities of the lung fields and the liver. Easy question, I think, for almost everybody here. What sorts of things are you looking at? Whoops. My apologies. Stop. I told you I'm new at this, but we're learning quickly here. So if you were looking at this particular X-ray, what sorts of things are you looking for in the relationship between the size of the heart and the size of the diameter of the thoracic cavity? All right. So as a general rule, if your heart's a third to a half of If your heart border or is a third to a half of the diameter of the thoracic cavity, that's within normal size. If it's much larger than that, so then you're looking at some type of pathology. And if it's much smaller than that, then you have to rethink about either the quality of your x-ray or what the underlying cause might be. Okay, so Jenna went up to the ward and she develops an increasing shortness of breath. I'll let you have a quick look at this x-ray. And really, I just would like you to sort of describe what you see. All right. So the vast majority of you answered D, a left-sided pleural effusion. Let's have a quick look at that. And that is absolutely the case. You can see that there is a fluid line, a fluid fissure, and this is the left side. So it is a PA view, and that's clearly marked on this x-ray. And there is a white out at this part of the x-ray, because what I didn't tell you, and I probably should have told you, is that she is not supine, she's actually sitting up, okay? Because she's on the wards, she's able to sit up to take her x-ray. So this would be a left-sided pleural effusion, and that would go along with her post-operative course. Okay, so we decided that we were going to put a chest tube in, and she's having worsening oxygenation, so she ends up getting intubated, brought down to the ICU. She's having difficulty ventilating, and you look up and you notice that she's now starting to have a decreased blood pressure. So they repeat the x-ray, and this is what you see. So sorry, I'll let you look at that again. What do you think might have happened? What do you think's happening given that x-ray? So about half of you have voted. I'm just moving along just for the sake of time, but about half of you have voted, and the vast majority have picked E, that Jenna has developed a tension pneumothorax. And that indeed is what has happened. If you look at her x-ray, she's got shift of all her midline structures to one side. She's got hyperinflation on the contralateral side, and she has a really narrow heart, and that's due to the increasing intrathoracic pressure within her chest, and that's decreasing her cardiac output. So those kinds of things are a clue to what you're looking at with your chest x-ray. I believe there's a second question, and everybody answered that. And you absolutely. So performed a needle thoracentesis. This is a life-threatening emergency. This is not one of those times when you don't get very many of these x-rays. We've talked about this in previous lectures, but because this is a life-threatening X-ray, the absolute correct course of action is to not do more investigations, but to actually do something. And in this case, it would be to relieve that pressure. All right, so this is a little 3-month-old boy. He doesn't have any respiratory symptoms. He was about to have an elective surgery, so they did a chest X-ray. What is interesting about this particular chest X-ray? Oh, let me launch, sorry. That's interesting. You won't be able to answer the second part of this until I show you. So just answer the first of those questions. Can people not see? No answers? Perfect.
Yeah, and we can't submit unless we answer all the other.
Unless you answer all of them? Oh, okay. Well then, that's helpful. Thank you very much. Thanks, Will. So what I'll do then is I need to show you the next X-ray. They're actually not related. Oops. Okay. So this is his twin brother. You know, his mom's obviously got her hands full right now. And he ends up in the emerge and with shortness of breath and increased work of breathing. And this is the X-ray of the twin brother. So let's go back to the pool. So what things could this possibly be for the twin brother? Some people picked, oops. Some people picked asthma. Some people picked croup. Some people described RSV bronchiolitis. And then let's go back, because this one's not quite as clear, but it will be fairly common. So let's go, the slide prior to this that had the brother in it, the 3-month-old little boy with no symptoms. There was nothing pathological there. He didn't have any respiratory disease. He was just extracardic. Wasn't important for this particular surgery that he was going to have, but it was something that was good to know. His twin brother, on the other hand, absolutely asymptomatic. And if you look at his X-ray, he does have perihilar haziness. He's got a right upper lobe collapse and a left lower lobe consolidation, and he's hyperinflated. And I would not say that I wouldn't say that it's incorrect to say that there's patchy infiltrates with underinflation, because there are parts of that, and it could be interpreted as a reticular granulopathy, but B is the only one that actually fits all of those things. This particular presentation is almost always consistent with RSV bronchiolitis. Okay, so although you may not see it, what's that?
Can I ask you a quick question? Sorry.
Sure.
I'm just wondering what makes this X-ray hyperinflated?
Right over here. Do you see, although it's not, can you see the widened rib spaces and the flattened diaphragm?
Yeah.
Right. So from here to here and here to here, those are quite widened rib spaces. The first thing you need to make sure is it's not rotated, because it will give you that appearance. So these are widened and they're flattened, and the diaphragm should be more cup-shaped, and it's fairly flat. So that's why I would say it's hyperinflated, and that's concurrent with any obstructive disease. RSV bronchiolitis is one of them. Okay.
Thank you.
Does that help? Yes?
Thank you.
Oh, you're welcome. Okay, so this poor mom really is having a hard go because now her mom is in hospital. And she's been in there for, grandma's been in the hospital for a little while now. She's had she's quite short of breath. She is on moderate amounts of oxygen, and this would be her chest x-ray. What do we think might be going on? Oops. Relaunch. I'm a bit of a slow learner, people. I'm so sorry. What might be going on with poor grandma who's now in the hospital on some oxygen and shortness of breath? Okay, so about a third of you have voted. This is a very good example when you have all these sort of perihilar markings and you've got this streakiness that's occurring in the bases of the lungs. This is a very common presentation of a bilateral pneumonia. It's possible that she had aspiration pneumonia, but the aspiration pneumonia generally shows up in the right upper lobe. So if you see an x-ray like this, we don't see it too often with children, but you will see it with older children, and you will absolutely see it with the elderly population. Okay, it's not necessarily in keeping with a cardiology course, but it gives you some idea of what you might see, because just because our little children have cardiovascular defects doesn't mean they don't get pneumonias. That's why it's there. Okay. I'm going to show you the next one. So this is a little 3-week-old boy. He had a history of a viral infection. He ends up in a merge. He's tachypnic tachycardic. He's poorly perfused. And this is his chest x-ray. What might be your thoughts for this? We're working very quickly through this, so you're just kind of having a quick look. So the vast majority of you have said something like myocarditis. So he absolutely has an enormous heart. So this heart ratio is far in excess of a third to a half of your cardiothoracic ratio. It looks like a big boggy heart border. And if you put that along with his history of a viral illness, that might give you a clue that this might be something like viral myocarditis. This way. How are you guys doing? We're almost done. So this is a brand new baby, newborn baby. And this is the baby's chest x-ray. And if you had the opportunity to ask some questions, what sorts of things might you ask? Whoops. My goodness, there we are. Look at you guys. Lots of people answered this. Excellent. So all of these things are relevant and they're all related, right? So maternal history is important. You'd like to know pre and post ductal saturations, but that also goes along with, is the baby cyanotic? And then one of the things you can do is a hyperoxia test to determine whether or not the cyanosis is due to a lung pathology, or is it due to a potential cardiac defect? So all of the above are things that we would normally ask, and usually you sort of ask these things as some general is a general approach. Like you just continue to go through them really, really quickly. Most of us wouldn't separate these things out. We would combine them together. All right, I think there's only one more. All right, so what two things do these babies have in common? Can you see both of those x-rays okay? It'll give you a hint. They are not twins. Okay. All right, the vast majority of people have picked D. So they both look like boot-shaped hearts, and boot-shaped hearts are consistent with tetralogy filo. It's always interesting because not every single boot-shaped heart looks the same, but on chest x-ray, if you look, I always think of them as a Christmas tree. They don't look much like boots to me, but this is the outline. It has to do with the anatomy and how you're going to see the heart borders. Any questions about that? We can get into the fine details, but I'm trying to make this. And I do believe, one moment. Yep, we are at the end of this presentation. Yep, that's it.